You're recording, isn't it? Okay, great.
Good morning, good afternoon, and good evening, esteemed speakers and participants from across the globe. I welcome you again to another ECD webinar series on the stories we tell, how myths and stigma affect children with disabilities. Before starting the webinar, we can go through the instructions. If you have questions for the speaker, kindly put them in the Q&A feature. To receive the certificate of attendance, participants must attend the entire duration of the webinar and complete the feedback form. The feedback form will be available once the webinar ends through the Give Feedback option that will be appearing upon closing the session. Please note that the Zoom closed captions are generated by AI and there may be instances where the translations are incorrect or misleading. We appreciate your understanding in that. Now it's my pleasure to welcome the moderator of the webinar, Dr. Rosemary Lobukoy. Dr. Rosemary Gatchell-Lobukoy is a consultant pediatrician and director of the Pediatric Clinic Karen in Nairobi, Kenya, with over 18 years of clinical experience. She holds an MBCH and Master of Medicine in Pediatrics and Child Health from the University of Nairobi. Dr. Lobukoy served as National Secretary of the Kenya Pediatric Association for 4 years, and currently she is the co-director of KPA's Early Childhood Development Program. She sits on the boards of the Kenya Pediatric Research Consortium and Kenya Children's Home and serves on the International Pediatric Association's ECD subcommittee. Her work focuses on strengthening healthcare workers' capacity to integrate ECD into routine care. Dr. Lopukoit is a certified trainer in ETAT Plus and pediatrics in disasters and recently co-authored Pediatric Considerations in Disaster Settings. She is passionate about ensuring every child gets the best start in life through comprehensive healthcare and advocacy. Over to you, Dr. Rosemary.
Thank you so much to the IPA team, and a very good afternoon, good morning, and good evening to wherever you're signing in from across the globe. And welcome to today's webinar about the stories we tell, how myths and stigma affect children with disabilities. Thank you once again for joining us. As pediatricians and child health professionals, we do far more than just diagnose and treat. We shape conversations, we influence beliefs, and often become the first point of contact for families navigating fear, uncertainty, and hope. In Africa, as in much of the rest of the world, disability is surrounded by powerful stories, some rooted in culture, some in misinformation, and many in stigma. These stories can delay care, they can limit opportunities for early intervention, and deeply affect how children and their families experience the world. Sometimes, even within health systems, these narratives go unchanged. So today's session is about recognizing those stories, understanding their impact, and learning how we as healthcare professionals can actively change them through the language we use and the counseling we provide and the advocacy roles that we take on. So we are very fortunate today to have experienced speakers who will guide us through today's topic. Allow me to introduce the first speaker of the evening, Dr. Ripudaman Singh Minhas. He's a developmental pediatrician at St. Michael's Hospital and an associate professor at the University of Toronto. And he's focused on child development and health equity in urban, immigrant, and refugee communities. He leads the WHO-recognized award-winning Our Kids Health Network on social media health literacy program with over 1 million followers and over 1 million views. He completed developmental pediatrics training at the University of Toronto and Holland Bloorview Hospital and holds an MPH from Johns Hopkins Bloomberg School of Public Health. Welcome to you, Dr. Ripu.
Thank you so much, Dr. Rosemary. Thank you so much to the IPA team for organizing this and for their kind invitation. I'm just going to shift gears to my slides, which should hopefully show up on your screen in just a moment. There we go. And before I start with my portion of the conversation today, I want to acknowledge the land that I'm joining you from today. So I'm located in Toronto, in Canada, which is the historical home to the guardians of this land, which were the Anishinaabe, Huron-Wendat, Haudenosaunee, and most recently the Mississaugas of the Credit First Nation. And I do wish to recognize their enduring presence in this space and am grateful to be able to join you from this land and recognize its legacy and history and my relationship to this land. In terms of the next 20 minutes or so, I'm going to be sharing with you my perspectives on our topic for today, and I've titled my section The Stories That Shape Care, addressing myths and misinformation in childhood disability, and we're going to talk about it from an ACD lens. I have no relevant conflicts of interest to declare as a part of today's conversation. I'm hoping that in our time, I'll be able to share with you ideas about how to analyze the role of cultural narratives, myths, and stigma in shaping disability-related beliefs and health behaviors, how to identify populations who are at increased risk of harm from disability-related misinformation and stigma, to discuss some trust-centered approaches to countering stigma and thinking about community-informed health communications with them to help build health literacy. And also really important as part of my journey has been in developing and implementing culturally humble strategies to improve communication with the families that we serve. So we're going to go through more about why does misinformation matter in our work with some cases. We'll talk about how to how to recognize and respond and discuss some frameworks around some of that and some tools that hopefully you'll be able to use as part of your practice, as I think this is an important concept for all of us. I think as we think about, stories and, the role that comes up for clinicians nowadays, it's really important for us to recognize the communities that we work with and the diversity of them. We know that over the last few years, we really recognize some hard truths, I call them, as a part of how families who are advocating for their child, participate in our healthcare systems, no matter where they are in the world. We know there are important differences in how they participate based on who they are, both in how they're accessing care, but also how they're taking in information that helps guide the care that they're accessing. We also know that online health misinformation is rampant. It lives in every language, in every platform, and is gaining momentum, unfortunately. And we also know that evidence-based information cannot be as accessible. We know for many parts of the world, actually seeing your primary care provider, if you have one, can be very difficult, but being able to turn to your phone or to turn to an online community is very accessible and often free. We also know that many BIPOC, and for me that means Black, Indigenous, and person of color communities is the term that we use here. We know that many communities from diverse backgrounds have a mistrust of healthcare institutions, and that may relate to painful histories related to concepts such as colonization, exploitation, enslavement, medical experimentation, and ongoing marginalization as well. With that, I think that also translates into our online space, right? Where a lot of the resources that we may be sharing with our patients and families in our encounters may not reflect them. With the way that medical colonialism has worked as well, globally, we do tend to see many of our resources historically have been Eurocentric or Anglocentric, and even if they are translated, have historically still required a high level of literacy, which can be difficult for families who are trying to take in this information. And this number still gets me every time, but when we think about the knowledge translation pathway, so this is this number that has historically been cited for, the time from when new science is published to the time that it is taken up into widespread practice, including into, our more marginalized communities. The number that's been cited in the past is 17 years from that first publication to the time of implementation to clinical practice widely. So really thinking about, again, how do we get families to understand the latest and greatest in science, which is continuing, to do research and create new knowledge. But how do we help them understand that as a part of, how they access and navigate care for their child? As a part of all of this, our team here created this program, which Dr. Rosemary mentioned earlier, which is called Our Kids Health. And so with it, I'll share a couple of slides to give you some context on how I come into this conversation. But we created Our Kids Health as a social media-based platform. We recognized over the pandemic, especially when people were isolated, when they were in lockdowns, that it was hard to get credible information. People more and more have been turning online. And we wanted to create a space where we could drown out the misinformation, hopefully, or try to dilute it at least, and create reflective messaging online. So I'll share some samples of some of our work, but Our Kids Health essentially uses a trusted messenger model, which is the idea of having clinicians on screen who reflect the diversity of the end user community, speak their language, look like them. We know that in in-person care that helps to improve how families take in information, and we try to translate that into an online space. So as a part of this, we launched our first channel, which was Punjabi Kids Health, and I'm Punjabi Canadian myself. And with the success of that first channel, we were able to scale up to now we have 10 cultural linguistic channels, which include Arabic Kids Health, Black Kids Health, which is Anglophone, Punjabi Kids Health, Pinoy or Filipino Kids Health, Hispanic Kids Health, Nos Enfants Afrodescendants en Santé, which is our Black Francophone channel, Mandarin, Cantonese, Tamil, and Ukrainian. And I'll share some links afterwards in the chat for if you'd like to follow along or learn more about the work that we do. With this, each of the channels then showcases healthcare providers from those channels, but really follows the lead from those communities around what are trends, what are beliefs and priorities for each of those communities, so we can give them the health information that they need, that they value, and that they see themselves reflected in. As was mentioned earlier, it's grown very quickly. So across our platforms, we currently have more than 1 million followers from more than 40 countries. It's growing very quickly with a new family following every 24 seconds and more than 100 million views of our infographics and short form reels and TikToks over the last year. And this is some of our team here where we've got our research coordinators and community coordinators who reflect the diversity of our different communities that we serve. They act as community liaisons where they lead a community advisory board for each of their communities, where we can then get a sense of, what are the priorities? Are we communicating in a way that makes sense? What are the myths and misconceptions that are swirling or gaining momentum in each community, so we can try to address those topics and priorities for them as well. They are the folks that do our translation and manage each of the social media channels as well, and really are the backbone of the work that we do through our Kids Health. Here are some samples of the work that we've done in the past. We really cover a range of topics from prenatal all the way up to adolescent. We tend to find our early childhood development content does very well, and again, I'll share some samples of that afterwards as well. But again, trying to think about what are questions that families have so we can try to answer them. Again, infographics, short form reels, and we sometimes will do Instagram lives where you can have a Q&A with an expert from your community and ask questions as well. And as a part of it, people ask often, how do you make sure that what you're posting on social media is rigorous? So, as we trace across this slide, the community engagement part is really helpful as we set our priorities. Everything goes through a double expert review to make sure that what we're posting is rigorous and scientifically sound. And then it goes through cultural adaptation and translation. The graphic design piece has been really neat for us to be able to do, where each of the channels has art and color palettes that are designed from artists from those communities. And then that's posted and online engagement happens. It's wonderful to hear in our comment sections and through our DMs or the direct messages we get, what are questions that people have? What are their perceptions? What are their priorities? And it's really great to hear that, so we can then try to address some of those and answer some of their information needs. I've got some QR codes on the screen here if you'd like to follow along our newsletter or our LinkedIn around some of the work that we do. And in the chat later on, I will share some links to some of the work that we do. So why does all of this matter when we're thinking about developmental medicine? So, just coming back again to the idea that misinformation impacts the work that we all do. It impacts how families perceive their child, how they perceive any concerns that may have, and can be a safety risk. It increases delays, refusal of care, can lead to conflict. And we're in a place with our developmental services that we all provide to really try to build trust, because we're seen as a trusted source of information. And also our role, however, it's interesting to think about, our role as clinicians has shifted. Many of us, and certainly for myself, trained as a diagnostician, where someone would come in with a concern, and I felt my role was to go through an assessment process to give a diagnosis and to give recommendations. That has shifted a lot, where now families come in saying, I read online that my child has signs of autism or has signs of global developmental delay. What do you think? And so, which is very different to, there's a preconceived narrative or notion already, and that for many of us, then our job has shifted to being someone who confirms or denies that, and gathers evidence to back up our recommendations accordingly. And we know many international bodies, including the American Academy of Pediatrics, are recognizing the growing impact of health misinformation and false health claims around our patient populations. And I've got a couple of cases, although you may have come across similar things as well. But here's an example of a 3-year-old who comes in with delayed speech and limited social engagement. Parents come in saying that they've been reassured by a WhatsApp group and online videos that tell them that boys generally talk late and that autism labels can be harmful. And it's taken a while then for them to come in to see you because they were reassured by their online community that they have. We also know online influencers can promote myths that autism is caused by, parenting style or vaccines, sore point there, which can increase parental fear. It can cause guilt and also can undermine our credibility as clinicians and lead to mistrust as well, leading to delayed referrals, diagnosis, and missed early intervention windows, which we know are really important as well. Likewise, here's a case of a child who is struggling academically and socially. Parents have taken in viral content online that has framed ADHD as being overdiagnosed, that stimulant medications are dangerous, can be addictive. Once you start them, you can never stop. It'll turn your child into a zombie. And then, misinformation can then emphasize also, moral or character explanations, saying that, there's a lack of discipline, or the school teachers don't really know how to manage your child, or maybe you're giving them too much screen time. So lots of other different kind of notions and narratives that can feed into how a family is taking in information as they come to see you. So, globally, some of the numbers are telling us that more than 2/3 of caregivers look for health information online. About half find information that's helpful, but more than half have told us that they don't know how to review the accuracy of what they're finding online and makes them vulnerable. We also know that people spend a lot of time on social media. So in 2022, we were hearing globally, it was about 2.5 hours per day that families were spending on social media, those adults. And so we know this is where families are, and that's where they're taking in information that impacts their care. Recently, actually including just this week, the Canadian Medical Association here just launched their survey results that was saying that Canadians, 43% of them identified as being highly susceptible to health misinformation and 5 times more likely to experience harm from following online medical advice from online groups or from AI chatbots as well. So really alarming as we think about the impacts of some of this work and how it impacts their care. We know it's important because this information impacts how decisions are made in households by caregivers, whether it's by parents or by grandparents or other family members. And these behaviors are health behaviors. How parents take in information, how they parse through it and process it, how they decide how they're going to access care for their child. Truthfully, even how they're going to parent, it has direct and indirect health outcomes. And so in the same way, when we think about health behaviors in other ways, so for example, when we're thinking about health behaviors classically, health behavior change cases are usually things like smoking cessation or, exercise increase in adults. Those are things that you can't just tell people. We can't just say stop smoking. And in the same sort of way, it's hard for us to just tell parents to change the way they parent. And so taking a gradual health behavior change approach is really important, and that relies on trust with us as their practitioners. I'll pause for a second to take a sip of my water, but I just was wondering if folks could share or reflect on, I don't know if our chat is enabled here, but if you could just reflect when you're referring for health information online for your families that you're working with, where are you referring them? What are your online sources if people ask? And what are the factors that you consider when you're choosing something that's credible that you can refer people to? So just take a moment maybe to think about that. What are those online resources and what are the factors that affect credibility? And so, usually I'm hearing from families or from colleagues that they're looking for something that's evidence-based, that's something that may be digestible at the right sort of literacy level, maybe for families as well. And it may be your local pediatrics organization, it may be advocacy groups, but really thinking about things that are evidence-based. We know that this information is really important. It can save lives, it can save families, and it can save communities overall because, again, information guides how we participate in our communities and our healthcare systems. So this was a new space to me as I started this work, and these definitions I've borrowed from our colleagues that are in media literacy and journalism. And the science behind that is really interesting to read about, especially as health and media literacy continue to overlap more and more in this day and age. So when we think about the term misinformation, that refers to false information that is there, it is not necessarily intended to cause harm. Disinformation refers to false information that is intended to manipulate or to cause harm or to damage or profit the person that is relaying that disinformation. And then an infodemic is a situation which I think we're finding ourselves in again now, where there's just too much information, both false and misleading information, but may also be, credible information, and that this information environment or ecosystem is overwhelming for people. It causes confusion, it can cause risk-taking behaviors, and very importantly, it can undermine the authority of credible health information sources such as us and our organizations. And as I was saying earlier, approaches to addressing misinformation in our families historically has been thinking a bit about it as a personal weakness. And I think it's important, again, for us to think about vulnerability because in the moment, practitioners, we can feel tired, we can feel frustrated, angry, impatient when families, are believing in misinformation claims. But at the same time, I think it's important to think about really this family trying to do the best they can with the resources they have, with the skills that they have, and their intentions for their child. And I think it's important to think about this quote really guides some of the work that I do in reminding us that it's not people who fail, but really systems that fail. So if we think about it from a systems level, that it's not the people or the patients that we're seeing that need to be righted, but rather thinking about the systems level approach that we can take. And we know that misinformation and disinformation do take a disproportionate toll on certain individuals. So when we think about the science behind this, vulnerability factors that have been identified include families from minoritized backgrounds, including racialized families, newcomers or migrant families, families from low-income backgrounds, from youth who spend a lot of time online as well and can get really impacted by those online environments, parents of medically complex children, and we know that all of this can drive mistrust, isolation, and then this echo chamber phenomenon where you can find an online community that believes what you believe or confirms what you believe, and then further confirms, and that can continue to snowball or increase from there. We also know that this is compounded by families who are in situations where they are under stress. They are in situations of fear or urgency, where they're hearing emotional testimonials or online stories from people, and they feel disconnected from their care provider or feeling like they're not being heard. We also know that there are practitioners or for-profit agencies, we'll call them, who will target their online marketing to families, will have false narratives online, which then can widen inequity for families, especially in those vulnerable early years. So as I go into kind of our kind of tools that I think might be helpful, so our team had developed this mnemonic just as a reminder of how do we approach some of these interactions. So if you have a family that's coming in with a situation where there's believing in misinformation and it could cause harm to their child, important to trust. So T is take a moment to pause, to take in what they're saying, recognize their emotion and their intention in that moment, try to understand their story of where did they get this information as you listen openly and humbly, and then try to share the science in a simple, accessible sort of way and try to talk it through with them. I think with it, it's really important to start with curiosity, recognize their core fears, avoid shame or sarcasm, because then there's a risk of further othering them and making them feel like the system is not there to treat their child, but is kind of pushing them in a way. And using appropriate sort of materials to help educate them, especially if that's something they can take home and process as a family or on their own time. And escalate really in situations where you think that harm is imminent for that child, again, in keeping with your local practices around ethics there. And what happens if we don't establish trust, right? That's a missed opportunity then to correct those false beliefs that can lead to delayed care or treatment refusal. It can lead to greater erosion of trust with the healthcare system. It can lead to greater risk of conflict or defensiveness with you as their practitioner, and lead to a weakened therapeutic alliance and increased risk of harm again because of the decisions that might be impacted by that. And so as I wrap up, I've got some conversation starters so you could adapt these to your situation, but here are some things that might be helpful as you think about in your toolkit. When I'm in that moment and I'm feeling frustrated, what are some things that I can do or say? So one situation, it might be something like, that's a really common concern. Can you tell me more about where you heard about that? This affirms their experience, but also opens up a dialogue without judgment. Also, I want to make sure I fully understand your thoughts before we talk about the next steps. What's your experience been so far? So again, this builds rapport by prioritizing their story, understanding where they're coming from, and looking at how you can align that with your medical agenda. Lots of families I work with are hearing different things online about this. What kinds of information have you come across so far? I think this normalizes confusion. It normalizes and recognizes that the parent or caregiver is trying to do their best, and they may be hearing various different things, and they're trying to take in information to make the right decision for their child, and also centers that there is a shared experience here that you can try to guide them through together rather than making it feel confrontational with them. Another a prompt might be, I can tell you really care about your child's health. Let's work together to figure out the best plan for moving forward. This affirms their intention. It refocuses on having a collaborative approach with you and helps to hopefully reduce defensiveness with them as well. So as I close, really, actionable points, I think, when you're recommending online resources to families, don't assume, maybe ask them what is accessible to them. Are there certain platforms where they prefer to access information? Would they prefer videos or would they prefer written format? And do they have certain language preferences or cultural sort of perspectives that might be helpful as you think about what information you're offering? And this will be different for all of us who are on the call today, depending on the patient populations we see. And then we have some families that really just want short summaries. It might be a busy parent who, while they're doing shopping, want to be able to kind of flip through something on their phone, whereas other families may want to sit down and want a really in-depth source for information or a peer-reviewed sort of piece of information for them as well. So thinking about who is it that's going to take in that information. Make sure that what you're sharing is evidence-based, of course, right? So review resources before you share them. I think with the communities we each work with, it's important to think about complementary and alternative medicine practices and beliefs, to think about how we can respect where those may come from, think about how that works with the sort of services and know-how that we bring, and trying to, again, not make people feel shamed, but kind of respect their perspective and remind them what we bring in terms of our knowledge as well. And build a repository of resources that are reputable and credible. So there is the Healthy Children website through the American Academy of Pediatrics. In Canada, we use Caring for Kids through the Canadian Pediatric Society. Kelty Mental Health is available as a great resource online. That's through British Columbia Children's Hospital here. Then you can also consider the Our Kids Health website as well, and our social media channels where we have lots of information that's shorter. And, I think it's also important to stay connected. It's important to do what they call in the journalism world social listening, understanding what do people believe, what are the trends of misinformation that are out there, and important to be able to listen actively and openly. I have some colleagues also that will actually participate in the online communities. You can create a decoy account very easily, right, where you can be in online communities or online bulletin boards and be able to hear, what is being recommended amongst these peer groups or these families to one another. And so that can help guide how we respond from a professional community standpoint as well. I'll pause there. And so if you want to follow along, I've got a QR code there and our website. My email address is there as well. I'd be very happy to connect if anybody has questions. Thank you so much for your time. And again, just want to remind people addressing misinformation isn't about ignorance, but really about building trust and rapport with families. Thank you so much.
Thank you so much, Dr. Ripudaman, for that excellent presentation. I think really we have to take it so seriously as healthcare providers that misinformation is actually a safety risk. And so it is our duty to tackle it and sort it out where we can. So thanks again, Dr. Ripudaman. Just a kind reminder to post your questions in the Q&A feature. So let me go to our next speaker, Dr. Carol Nerima from Uganda. Dr. Carol is a developmental pediatrician in Kampala, Uganda, with over 15 years of experience in child health. Her work focuses on neurodevelopmental disorders, family well-being, and parent advocacy. Her research includes ADHD and rehabilitation of children with developmental disorders in refugee settings, alongside advocacy for equitable services in Eastern Africa. She supports Uganda's Ministry of Health and represents the East African Academy of Childhood Disability within the International Academy of Childhood Disability. And she will now give a presentation on how misinformation impacts children with disabilities. Welcome, Dr. Caroline.
Thank you very much, Dr. Rosemary. I am Dr. Caroline Nerima. Excuse me. Dr. Rosemary, I hope I'm clear. In case my video starts to hang a lot, please let me know so I can turn it off. Sometimes my bandwidth is a problem.
You can switch off the video
Dr.
for now
Caroline
if you
Nerima.
need to. You can switch it on after
Okay.
the presentation, so just switch it off for now. Thank you.
All right. So are you able to see my slides, Dr.
Yes,
Rosemary?
yes, we can. We can see them clearly.
Okay, thank you. Second. So I'm Dr. Nerima, as Dr. Rosemary has mentioned, a developmental pediatrician from Uganda. The only disclosure I have is that I am a mother of an lovely autistic teenager. That is the only disclosure that I have. So thank you so much, Dr. Ripu, for your wonderful introduction to this very important topic. I will now delve into how myths and stigma affect children with disabilities. And I'm coming from the lens of a low resource setting, extremely low resource setting, where myths around disability are rife, and they do affect equitable allocation of resources, access to support services, and even diagnostic services. And so before we discuss this data and what we can do, we must discuss the stories, because the stories society tell about disability and the stories families are forced to carry. This is not only about services, but about dignity, because narratives drive behavior, especially in this part of the world. And across continents, the language around disability changes, but the effect is similar. So children are either invited into community life or they are pushed to its margins. I'll share this very sad story about a story that was posted in Al Jazeera. So in this section, I'll focus on how stigma affects the child. So in this particular story, I think you can see that this was an interview of a couple of families, but this particular was picked in a very, very remote part of Uganda where they found a 14-year-old boy with quite profound autism who was being tethered to a tree during the course of the day because his parents had to go and fend for their families, including working their gardens for subsistence farming for a living. And he was being kept tethered to a tree because it was the only way to protect him. But also it was driven by the fact that the community thought he was and for his safety, he was tethered to a bed because found him, he was likely to be harmed, but he was also likely to lash out to people who constantly did not understand him. So families often struggle with mental health, help seeking. But in our settings, particularly in low resource countries like ours, everything is left to the family to figure out. And whether in Kampala, Mumbai, or London or Toronto, the family is the place where stigma is either absorbed or transformed. And this was a landmark ruling in Uganda, which is relating to the same family where, with the support of an NGO that found this child and took care of the child, but also felt the government was not doing much to support these children. The government was responsible for caring for every child in the country, not only those that have no difficulties in development. And so the government was sued. And by support from the Senate and the local, actually they sued the local government of that district. They won the case. The purpose of the suing was to force the local government to start to provide services for families with disabilities, especially in that part of the country. But in as much as the ruling was made and the families won the case, there has not been much progress beyond that. So families generally are our strongest partners as practitioners of developmental medicine and pediatrics, but often the families are left to carry the stigma and the challenges that come with a system that doesn't respond simply because of the narrative that these children are not going to benefit the nation probably. And so if we have limited resources, we must as well put them to where we can get the biggest bang for our buck. So why does this matter globally? The numbers confirm what families have told us for years. Stigma is not only painful, but dangerous. And so in this study, it was published in the Lancet, they found that the prevalence of violence among children with disabilities was 31%. And children with disabilities had double the odds than those without disabilities to experience violence. And they are more likely to be out of school. For example, this little boy that was found in the tree obviously was not in school. And they're likely to be, even when they're enrolled, they're likely to be given less work. And so that's a form of exclusion, a form of stigma, even when they could be able to support these children. So what are families up against? So myths often frame disability. In our part of the country, and I think maybe other parts where culture is such a heavy driver of access to services, a heavy driver of resources. Disability is often framed as a curse or moral failure or a spiritual punishment. This picture depicts that the boy that I mentioned in the first slide, who is 14 years old, is being carried by his mom. And you can tell that the people in the small kiosk are watching her. And she mentioned that prior to trying to get help from an NGO, she had attended traditional healers because she had been told her son was cursed or it was a problem with his family. But of course, there was no improvement. This particular boy had actually been a victim of poisoning by workers who had deliberately left a little bottle of poison just next to his home, knowing that he was going to drink it because it was quite impulsive. And they actually wanted him to die because the village considered he was a curse. So caregivers in this case are often blamed, especially the mothers. We see lots of families split because fathers will say in our settings that we don't have such children in our families, so this must be from your side, so you must leave. There's also pressure to seek traditional course for medicine. And this medicine is often not going to respond to the family needs, family support needs. But if you do not attend this traditional medicine, then you are seen as the problem and the reason why your child is like that. So it wastes the time of the parents who could otherwise be seeking answers. But also you don't, in a setting where the answers are so few and far between, and I'll share my next slide, another very sad story is, where do they go? Where do they go in a setting where we have very limited trained practitioners? So sometimes the stigma and the myths may not be easily handled in the community because the trained practitioners to handle these myths are not there. Right. So in some African settings, it may be seen as spiritual blame, but in parts of Europe and North America, it may appear as low expectations of subtle social exclusion. So the stigma may appear just with subtle social exclusion, subtle low expectations in the educational settings. So it looks different in different continents, but it's the same harm. And the harm is exclusion. Stigma leads to exclusion and lack of participation. So what is the impact on families? We have 3 types of stigma. In a study that was done in Ethiopia, there were 3 types of stigma that were identified. And we have public stigma, courtesy stigma, and affiliate stigma. So public stigma is when we have negative community attitudes and discrimination, which is what we are all familiar with.
Thank you.
And then courtesy stigma is stigma directed at the family members because of association with the child. So for example, when you mentioned that your child has developmental condition and then and then your peers will say, things like, oh, sorry, or things like, oh my God, what are you going to do? It almost makes you feel like the child is cursed, is a problem. And then you start, even as a parent, want to sort of dissociate with your own child, even though they think that they are offering a courteous comment. So the other kind of stigma we may experience is affiliate stigma, where caregivers then internalize the blame and the shame. And this is the most common and the most dangerous and the least identified by health workers, particularly because I guess in settings where there is so little to give, often parents are told, be strong, or things like, it will be fine, it could have been worse, and not identifying what the parent's actually struggling with. And often in my clinical practice, mothers will say, I don't know what I did in my pregnancy. Did I take something, doctor? It's always blame. And blame can lead to other mental health problems, like we shall see, which will impact the participation of the parent in the child's rehabilitation process. So this 3-level model is useful across continents because it explains why support must target the community, the family unit, and the caregiver self-belief all at the same time. So what do we often see? The first impact we have is mental health impact, like I've been mentioning. So the picture of this gentleman was probably that same story. And this man was a 21-year-old man at the time of publishing who was tied to a pole in his hut. He lived in a homestead with his parents and was tied in a home in his hut because he was extremely violent. And for his own safety, he was tied there because the neighbors wanted to fight with him because he was very, very aggressive. Her caregiver said the only thing he knows is his son was born with spots on his face. So clearly a condition was not identified and appropriate management wasn't given. And his only hope was, if God does not intervene, he's going to die this way. And by dying this way, he meant tethered to his heart, sleeping on the mat. So stigma is often consistently associated with poorer caregiver mental health, and in the autism caregivers, the parents often live in a state of despondency. Often the question is, what will happen when I'm not here? Parents often give up. And this courtesy stigma in studies has shown that it predicts later stress, anxiety, and depression. And I don't know how many of us often ask parents how they are dealing with other aspects of their lives, if the other aspects of their lives are moving on, because often parents will stop. Their lives often stop at the point of diagnosis. And siblings are often left out. But these are the families, the children who live within these families struggle. And they struggle between guilt and fatigue of having to constantly look out for their siblings, and may also face lower peer level interaction because of that sibling that is attached to them. So a 13-year-old sister of a 13-year-old boy, she said, it makes me sad when I see people make fun of my brother and isolate him. She was attending the same school with her brother. So there's this guilt of, I need to take care of my brother. But then there's this feeling that my brother is a burden. I'm guilty. I feel guilty about that, sorry. But then I I can't help him, but I help him. But if I help him, then no one wants to be around me. So siblings also struggle, and they are always the silent other uh, patients in our rooms that we probably never ask how they're dealing with their siblings. Mental health collapses of the caregiver, who will sustain the child? And so it's something so important that we must look at when we are handling parents, families of caregivers. The other thing that is affected is the family functioning and the quality of life. Families raising these children have reported lower family quality of life than those who are in comparison with those with physical health conditions. Because physical health conditions are easily recognizable, and people will often offer empathy when this child is in a wheelchair, but not when a child is having a meltdown. So families will struggle and will not, for example, will avoid to go out in public because their children are going to cause a scene, and there will be not much sympathy. So they will have limited social participation, isolation, and less time for personal relationships or leisure. There are also future planning concerns, and the persistent anxiety about the future of this child is something that never leaves the parents. So there are also systemic barriers to access. So in low resource settings, stress comes from both the stigma, but also the scarcity of resources. However, in higher resource settings, we see that it may come from fragmented systems and hidden exclusion, like I spoke about earlier. So I want to ask clinicians here or any other practitioners in any cadre, do we measure family quality of life as a core outcome in our clinical rooms? Just as Dr. Ripo mentioned, that we have been trained to be diagnosticians, but this goes beyond just diagnosing a condition. We must be able to measure the family quality of life as a core outcome, because it has a huge bearing on the child's functioning and well-being. So the other impact we find, apart from the mental health and the functioning, we also see an impact on health seeking and care pathways. Stigma delays the moment families reach effective care, and delay has developmental costs as we know it. Often in my setting, parents will say things like, he wasn't talking, but his grandmother said that his father also talked late. So I wasn't worried. That's why I'm coming at 5 years. And we've lost a lot of time in the time of very significant plasticity. So the pathway is often a fear of judgment leads to secrecy and then late presentation. And when we present late, then the care is crisis driven. It's firefighting and not a gentle and very consistent support towards the developmental achievement of skills. Some caregivers also report being pushed into harmful or non-evidence-based traditional practices due to social pressure. But also now we are seeing a huge push towards, like Dr. Ripo mentioned, online information that is sometimes harmful, but also sometimes not beneficial. Particularly in Africa, we have because there's scarcity of resources. Often families will look for where the resources for support are free and available. And of course, that is online. So you'll find parents are not willing to pay out of pocket for rehabilitation, because we pay out of pocket for the most part, but then they're willing to fundraise for a very big fundraise for interventions that are surgical interventions, for example, that are out of the country, hoping for a miracle. So it's driven by desperation, but also the lack of resources, but also stigma. Everybody just wants their child to talk, to be like others. And so lots of services, the lack of services drives a lot of the challenges we see here in our setting. So the other impact we have is the schooling and participation consequences. And in my practice, this is the number one question that parents come with. Where is he going to go to school? I want my child to go to a mainstream school. And the reason they ask for mainstream school, even before they understand their child's abilities, is because they don't want their child to be excluded or to be isolated or identified in a specific educational setting that will label their child. So stigma and low expectations undermine educational participation and learning opportunities. Many parents are happy to have their child in a mainstream school with no support, but without a label. And I think sometimes this is driven by the fact that the community, the stigma that is placed around these children with developmental disabilities is so strong. In one of the local languages here, the direct translation of a child who doesn't talk, if you translate it to English, it means a stupid child. It's a general term that is given to children who are hearing impaired or cannot speak, or children who have behavior difficulties. That is given. Either they are called mad or stupid.
What's it saying?
And that will obviously drive a parent to not go to that particular school, even though the child is really not speaking. So for children with learning disabilities, the stigma is not so overt because children often have no behavior difficulties, obvious behavior difficulties, but the stigma is linked within the classroom because they have to often repeat a class, or the previous grading systems where marks were displayed on the boards and everybody saw who was constantly failing a specific subject. It is linked with lower self-esteem and poor psychosocial adjustment, which will then breed behavior challenges. So broadly, child disability data show major school participation gaps. And sometimes we have institutions that are saying they're inclusive, but maybe the classroom for the children with who need extra support is at the back of the school, or it's where they could afford to put a ramp, or it's where they could afford to have the children hidden. So are we really excluding, or are we just tolerating this? To think about as parents, as practitioners, is our definition of inclusion attendance only or attendance plus meaningful learning? So the other big thing that especially we find in our setting is child protection. And these are just pictures that are showing the little boy who was tethered to a tree and this gentleman who was tied to his hut because he was often violent himself. And then the other sad story is Kat, who has a 4-year-old son called Edwin, but she isn't aware that she's a boy's mother. She has quite severe intellectual disability. And her parents identified that she was pregnant when she was about 7 months. She does not know who the father of the child is, but at that point is when the next door neighbor disappeared. So her parents are workers on a sugarcane plantation. The suspect next door, who they think raped his daughter, raped her and was able to access her because she was kept in a kitchen outside while they slept inside the house. They kept the child outside, possibly because of the fact that associating with a child means that they would get, sometimes they think maybe some of these conditions are spiritual, and so the spirits that have invaded this child would invade the family. So because she was not protected adequately, she was accessible to the next door neighbor. He has never been charged to this day. So stigma is also a protection issue, not only a societal attitude issue. And children with disabilities often have high exposure to violence. Their abuse is often underdetected. And when detected, communication barriers make it hard for anyone to pinpoint who the perpetrators are. So there's a call for integration. Disability responsive safeguarding must be embedded in health, school, and social protection systems. And protection failures are global. What differs by continent is just the reporting capacity and legal enforcement, as well as access to child-friendly justice. So most of our child protection systems here are not designed for children who communicate differently. So what has been seen to protect families? Family acceptance is one thing, and that leads me back to the caregiver stigma, the internal stigma that the caregivers often face. It's one thing we must address always in our clinical rooms, because when a family is able to accept their child, they're able to advocate and able to seek services without shame or guilt. Social support is equally important. In Africa, or I think in everywhere, we say that it takes a village to raise a child. And so, for example, if a child elopes, the village is aware where the child comes from and they know the child has developmental condition, they're likely to not harm the child or think they're a thief and likely to carry them back home, to guide them back home or protect them from any other people. So we also need better community awareness, also protects families, and it reduces the internalized stigma. Parent coping skills are also quite important, including mindfulness-related skills like anxiety, respite care, and they may buffer stigma's mental health effects. Across the continents, the message is consistent. Families do better when they are connected to trusted people and not just information. So beyond just reading an online content from an influencer, who the parent comes into contact with, whichever practitioner must be able to find out if the parent has coping skills and what they are using to cope. It may be harmful or helpful to the child and to the family. Are we giving families a leaflet or are we directing them to a support network? That is something to think about. So what is a call to action? We have 3 levels of call to action. We have a clinical level. We should use non-stigmatizing language and model respectful communication, like Dr. Ripo mentioned. Non-judgmental. We must also screen the caregivers for distress routinely and then give families concrete coping and communication tools. At the community level, we must be advocates. We must be the ones that be the trusted local voices with the faith leaders, the parent champions, teachers, and youth advocates. We must help the building of parent-led support groups to reduce isolation and share practical strategies. And then we must use contact-based inclusion activities in schools and in community spaces. So community-level solutions in Africa should be culturally grounded. I mean, in different parts of the continent should be culturally grounded. What works in East Africa may look different from Latin America, the Middle East, or Europe, but the principle is the same. And I want to ask all of us here as we think about it, are we the trusted messengers? Or are we the ones that are isolating and constantly telling people this is wrong, but we're not showing them what is the right thing? We have an opportunity as practitioners to be the trusted voice in the room. And then the last point is at the systems level. We must continue to build inclusive education and protection pathways that are funded, monitored, and enforced. We must also support the embedding of family-centered psychosocial support and invest in multi-level anti-stigma interventions. And I'm grateful for the different platforms that are opening up online. And honestly, in the lower to middle income countries, the intervention, there's a big gap that exists within what is available and what is needed. So we must continue to advocate for systems level improvement. So in conclusion, when we change the story, families are able to reclaim possibilities. And there's nothing like a parent that has lost hope. We need to reignite hope, and hope may look different in different settings. Not necessarily hopeful for healing, as some families would require or ask, for example, things like, is he going to stop being this way? But possibilities of what is happening and point towards what is the current abilities the child has and move them towards focusing on the positives and not just the negatives. Look for the possibilities. So myths create stigma, and stigma harms all family outcomes. Families are not passive recipients, they are partners and leaders. So right now we need family-centered multi-level action in our different continents. These are my references. Thank you very much for your attention.
Thank you so much, Dr. Carol, for that presentation. And I think that was your son we could hear in the background. So we're very happy to have him join us today.
I'm sorry, I kept pinching him to.
No, we are happy to have him here.
I just had to tell him, shh. Kept saying,
He's
shh.
very welcome.
Thank you.
Yes. So I can see that there are no questions in the Q&A. So I just wanted to really get your parting shots. What do you want people to go away with? So I can start with Dr. Ripo, and then we'll take it from Dr. Carol.
Sure. Dr. Carol, thank you so much for that. I learned so much from you, and so much of what you said resonated with me. And I think take-home points, from a little bit of both of what we said, but certainly I think around the importance of listening with curiosity and humility to the families that we work with, understanding their perspectives and recognizing how much that guides, how they participate in care with us as partners. So I think all of that is really important to recognize. And similarly, from a Canadian context, so much of what you said resonates. We've got lengthy wait lists. We have care available, but there's long wait lists, and families really bear that burden of, whether you're waiting for a diagnosis or whether you're waiting for therapy or for funding. Families are experts because they're living it every day. And so I think honoring their expertise and bringing that together with what we bring as clinicians or as intervention specialists is really important. So I think the importance of learning is what I'd recognize there.
Thank you, Dr. Ripu. Dr. Carol?
Thank you very much. Thank you for I just want to ask every clinician or every practitioner here. Let me just take off my video because I think I'm hanging. I just want to ask everyone who is in this room that beyond the diagnostics, every time you come into contact with a family, ask about how the siblings are doing. Ask about if the union is still intact or has it been affected by this child. Not that you probably are going to be a lawyer, a divorce lawyer or anything, but it's important to care for the family, really important. And if the family is thriving, the child is likely to thrive. Thank you.
Thank you so much, Dr. Carol. And I think it's really important for us to remember that as pediatricians, we have a unique and trusted voice. Families listen to us, communities listen to us, and we are in a powerful position to change harmful narratives and replace them with the messages that are accurate, compassionate, and inclusive. So finally, changing the story is not about having all the answers, but it's about listening, validating family experiences, and standing with them as partners. So I'd like to thank our speakers again for their insight and generosity in giving their time and their expertise to us. I would like to thank the IPA team for all the work in setting up this webinar. And thank you to all the participants for your commitment to improving the lives of children with disabilities. So let us continue to be intentional about the stories we tell as we continue working for every child, every age, everywhere. Over to the IPA team. Thank you so much.
Thank you everyone for participating. On the screen, you can see that we have shared the feedback form. You can just scan the QR code given on the screen and just fill up the feedback form to receive the certificate. Thank you all.